So, first question, factors influencing the wound healing. So, the factors influencing the wound healing. What is wound? Wound is the break in integrity of skin and continuing tissue. There will be a break in the integrity of the skin or a tissue, that is called as wound. What is wound healing? Wound healing. The wound healing is the process of healing of the wound by regeneration and repair. The mechanism whereby the body tries to restore the integrity of the injured part. Wound healing is the process whereby 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 the body tries to attempts to restore the integrity of injured part. That is wound healing. What are the factors that influence the wound healing? So the factors that influence the wound healing is broadly categorized into two groups. One is systemic cause and another one is local factors. Systemic factors and local factors. Your systemic factors includes age. Older age lower the wound healing. Nutrition. Malnutrition baby, zinc deficiency, copper deficiency, manganese deficiency. Malnutrition, zinc deficiency, copper deficiency, manganese deficiency will people have poor wound healing. Next, metabolic disease, trauma, immunosuppression, smoking, and any vitamin deficiency, any connective tissue disorder. These are all the systemic factors: age, nutrition, metabolic disorders, trauma, immunosuppression, smoking, connective tissue disorder. This can be remembered with AMN: age, metabolic disorder, nutrition, tics, trauma, immunosuppression, connective tissue disorder, and smoking. Next is your local factors. The local factors include mechanism of injury, mode of injury, type of injury. Is there any ischemic or a necrotic tissue? An exposure to ionizing radiation, foreign body exposure. So these are the local factors that are related to the wound healing. So this is your first question. Next question is crush syndrome. What is crush syndrome? The crush syndrome is more analogy to that of the compartment syndrome. What does crush syndrome means? Whenever there is a crush injury, the crush injury will lead to crushing of the muscle. This crushing of the muscle will cause release of myohemoglobin into the circulation. There will be crush injury, so that cause crushing of the muscle, that leads to release of the myohemoglobin into the circulation, that causes acute tubular necrosis or acute renal failure. Acute tubular necrosis or acute renal failure. So this is the overall pathology that is happening over the crush syndrome. There will be muscle crushing, so that leads to release of the myohemoglobin into the circulation, and whenever this myohemoglobin is released into the circulation, that leads to acute tubular necrosis or a acute renal failure. So what is acute tubular necrosis? There will be kidney injury due to the death of the renal tubular epithelium. Tubular epithelial cells die, that causes tubular obstruction, that leads to decrease in the GFR. There are several causes of ATN. First one is your ischemic ATN, and another one is nephrotoxic ATN. Your nephrotoxic acute tubular necrosis is due to the aminoglycosides amphotericin B drug causes, whereas your ischemic ATN is based upon the shock, severe dehydration, malnutrition, or a hemorrhage or a myohemoglobin causes. So what happens whenever this tubular epithelial injury do happen, that leads to sloughed cells form the muddy brown granular classes, that muddy brown granular cast that cause tubular obstruction. There will be filtrate leaks back to the interstitium, and these causes decrease the GFR and acute renal failure. There will be cell death in the tubular cells, that leads to obstruction in the tubular, that causes GFR to be decreased. So this is your overall cause. Next, this is your crush syndrome. Now, what are the causes? Basically, RTA. Causes is your RTA, industrial accidents, any air crash injury, tonic wet, or earthquakes. These are some causes that are related to the crush injury. What are the clinical features that are related to the crush injury? There will be increased tension in the muscle compartment, that leads to ischemic changes, loss of 6p, painlessness, pain, pulselessness, pallor, and you have your paresthesia, pressure changes, pigmentation. These all are seen in the as a ischemic change. First one. As said, there will be AKI, there will be urine discoloration. There will be urine discoloration, and it will become scanty urine. The patient will be toxic state. He will be restless, he will be apathy, he will be delirious. Why? Due to the onset of the uremia like features. What are the complications that you could expect in the crush syndrome? The complication you would expect in the crush syndrome would be acute renal failure or acute kidney injury, toxemia, septicemia, gas gangrene. Next, what can you do as a treatment? The treatment can be done with fracture fixation. Before that, you need to do fasciotomy, because there is a increased compartmental pressure, so you need to handle. Fasciotomy should be done, and you can give Rio macrodox or mannitol. There will be urine acid doses. So to prevent this, alkalinization of the urine done with sodium citrate or sodium bicarbonate, and Other other measures other measures like catheterization, urine output monitor, antibiotics, blood transfusion. If complications, treat the complications. So this is crush syndrome. Next, keloid. Keloid. Keloid is a excess abnormally stretched type 3 thick collagen tissue bundles. Excess abnormally stretched type 3 collagen tissue bundles. Type 3 collagen tissue bundles. Aligning in a same plane. Aligning in a same plane as epidermis. Extends beyond the skull. Extends beyond the skull. Okay. So it is familial. Females. Blacks more common. And the pathophysiology here is defect in the maturation and stabilization of collagen fibers. Okay, next, most common site, sternum, upper arm, chest wall. So they grow for long period. Grow for long period, that is more than 6 months. Each may be present and there will be painful condition. Sometimes they may be associated with pigmentation too. Pigmentation may also present. So this is about keloid. Keloid over. Next, hypertrophic scar. Hypertrophic scar is an ulta. Here, thin type 3 collagen fibers. Raised, limited, less than 6 months growth with no genetic predisposition. Self-limiting condition. Here main words are type 3 collagen fibers. Type 3, type 3, type 3, type 3. Here also type 3, type 3, type 3, type 3. That word is important. All other things you can know. All others are simple only. So the treatment for both. So treatment for both are same. Intrakeloidal triamcinolone at a regular interval 7 to 10 days of 6 to 8 injections is given. And you can give pressure garments and local molds can given. In keloid you can give methotrexate, vitamin A and C, silicone gel sheets, all these can be tried, and Nd:YAG lasers can be given to the keloid. DD for keloid is hypertrophic scar, DD for hypertrophic scar is keloid. Next, ulcer edge.